We all know that heart attack is associated with very high mortality, and normally heart attack occurs because there is the atheromatous plaque in our coronary artery. It either erodes or it ruptures. That exposes the material atheroma. We all know that heart attack is associated with very high mortality, and heart attack normally occurs when atheromatous plaque which is present in the coronary artery ruptures. That exposes the thrombogenic material of this atheromatous plaque to the circulating blood, and that results into formation of clot. And of course, we treat these patients of heart attack with angioplasty, with antiplatelet drug and other conventional treatment. But the problem comes that these patients are very prone to have second episode or third episode of cardiovascular events. And most of these events are because of similar plaque present in other coronary arteries, which are of course in a mild to moderate in severity. So it is very important for us to stabilize these plaque, because if one had in acute coronary syndrome, it is basically a pan coronary destabilization of the plaque, means if majority of these plaques are also vulnerable to rupture. So in these patients we have to aggressively lower the LDL cholesterol, and we have to bring down the LDL cholesterol level to the targets. And the target of LDL cholesterol in patients with heart attack varies from less than 50 milligram per deciliter to less than 30 milligram in some group of patients. So in my talk in this conference, there were 6 key messages which I conveyed to the audience, to the delegates. The most important is that when patient with heart attack comes to the emergency department, immediately you give him high intensity statin, which means 80 milligram of atorvastatin or 40 milligram of rosuvastatin with 10 milligram of ezetimibe. Number 2, you send blood sample, lipid profile sample immediately when you are sending other blood samples, and this lipid profile should include lipoprotein A if it is possible. Number 3, once you get the report of lipid profile, then you know how much LDL cholesterol you have to reduce. So depending upon that reduction, you can decide the combination of lipid lowering drug. In majority of patients, you can continue with high intensity statin plus ezetimibe, and in case you require additional lowering of LDL cholesterol by 20 milligram, you can add either bempedoic acid or bile acid sequestrant depending upon availability of this drug. And if more than 20% is required, lowering is required, then one can consider using PCSK9 inhibitor. But since this is an expensive drug, it has to be a shared decision, because you have to discuss with the family the benefit of using this drug versus the expenses which they have to pay for it. And repeat lipid profile at 2 weeks time. By this time, with the treatment which we have started in emergency department on the day 1, majority of patients will achieve the LDL cholesterol target, and in case it has not been achieved, then we can add additional LDL cholesterol lowering drug, so that the objective is very clear. We have to achieve the LDL cholesterol target to as early as possible, definitely by week 4. And in those patients in which, despite using 4 available lipid lowering drug, we are not able to achieve the LDL cholesterol target, then you have to keep the possibilities of familial hypercholesterolemia or high lipoprotein small a. Patient should be investigated for it, and then only one modality which is available, which is not currently available in our country, is lipid LDL apheresis. And by this method, we will be able to prevent recurrent cardiovascular event, and definitely if we are able to prevent recurrent cardiovascular event, we can definitely reduce subsequent mortality and other complication. Thank you.